आज लाहौर में इस वक्त काफी एक्टिविटी चल रही है, एक दो वर्कशॉप्स हो रही हैं और इसलिए कुछ लोग उधर भी बिजी हैं। तो लेकिन है कि कोई ना कोई आजकल माशाल्लाह एक्टिविटी इतनी ज्यादा है, कोई ना कोई 150 फिर ओवरलैप होती हैं, फिर होनी पड़ती
Exactly.
हैं। हाँ जी,
बिल्कुल सर, एग्जैक्टली दैट्स रियली गुड कि एकेडमिक्स इज ऑन द हाईएस्ट लेवल
जी
और
बेटा
अल्हम्दुलिल्लाह
बिल्कुल।
ये इसी तरह चलता रहे तो हर कोई अपनी कंट्रीब्यूशन करे फॉर द
और
बेटरमेंट एंड इम्प्रूवमेंट ऑफ द यूथ।
एग्जैक्टली, तो अच्छी बात जी है ना बेटा, पिछले को 8-10 साल में जो हमने देखी है, जो डेवलपमेंट ऑफ सब स्पेशलिटी है ना,
जी सर,
ये बहुत अच्छी हो रही है और बड़े रिक्वायरमेंट जरूरत थी।
Alhamdulillah, sir, all this credit goes to you people, our seniors, our mentors.
मिलजुल के एक एक
flourish
बंदे की
किया।
कंट्रीब्यूशन है और
अल्हम्दुलिल्लाह।
मैं ये कहता हूँ कि ये हम सब का पीओ है और सबसे
अल्हम्दुलिल्लाह।
टॉप प्रायोरिटी पे पीओ यही होना चाहिए। बाकी छोटी छोटी चीजें बात की हैं और इसमें आप सबने मिलके जो फोरम्स, सोसाइटीज, फिर रिस्पेक्टिव इनकी फेलोशिप्स की हैं, उसका बड़ा लोगों में इंसेक्टिव पैदा हुआ है। आप देखेंगे फेलोशिप के लिए लोग कितने एंथुजियास्टिक होते हैं और
जी।
विलिंग वर्कर होते हैं और वो इट कीप्स ऑन इम्प्रूविंग, चलता रहता है और बेहतर होता रहता है।
Right, I 100% agree about this, sir. और अब तो वर्ल्ड तो सब तो अब हम we have one step ahead now. It's a super specialty. That things have gone from subspecialty to super specialty. Mean if I'm a sports surgeon, if I say I'm a sports surgeon, I have to have a specified my this subspecialty into something like knee, into shoulder, into ankle, something very specified for myself.
एग्जैक्टली। आज से को 25-30 साल पहले जब हम जनरल जेबीजीएस होता मेरे पास आता था, पढ़ते थे तो उसमें रोटेटर कफ के बड़े वो होते थे। हमारे यहाँ इतना अंडर डायग्नोज होता था कि कभी भी इसके ऊपर ट्रीटमेंट होता ही नहीं था।
Agreed.
और डायग्नोज ही नहीं होता था, डायग्नोज ही नहीं होता। और सीनियर ऑर्थोपेडिक सर्जन हम सब लोग होते थे बस कि जी बस ये एडिसिव कैप्सुलाइटिस ही है, पर ठीक है। पर इसका प्रेवलेंस इतना ज्यादा है, इतना ज्यादा है, खासतौर पे शोल्डर पे तो पूरी दुनिया में इतना काम होना शुरू हो गया
जी।
कि वो अपने सैन डिएगो शोल्डर के सेंटर से बहुत बड़े बड़े
जी।
और बड़ा वहाँ रिसर्च बुक होता है, ये सारी चीजें वहाँ चल। तो जनाब आपके पैनलिस्ट जो स्पेशलिस्ट हैं वो भी आ गए माशाल्लाह। अबू बकर साहब, अबू साहब अनम्यूट कर लीजिए। अस्सलाम वालेकुम बकर साहब।
अस्सलाम वालेकुम।
क्या हाल है? ठीक है, खैरियत से हैं?
आप ठीक हैं, खैरियत से हैं?
जी बिल्कुल ठीक ठाक, सब खैरियत है, ठीक है, जबरदस्त। आज बड़ी
तस्वीर आ गई?
जी बिल्कुल, तस्वीर आ गई, आवाज भी आ गई, तस्वीर भी आ गई।
चलो फिर तो सब कुछ हो गया।
असल में हमने अपने
अस्सलाम वालेकुम सर।
वालेकुम अस्सलाम। आप ठीक हैं, खैरियत से हैं?
अल्हम्दुलिल्लाह सर, अल्लाह का एहसान से। थैंक यू
अस्सलाम
फॉर
वालेकुम
जॉइनिंग
सर।
सर। ऑनर।
शुरू करें।
बाजू साहब
जी अभी ज्वाइन कर रहे हैं लोग?
हाँ, 12 तो हो गए मेरे पास।
अच्छा, होते जाएंगे, ऐड होते जाएंगे मेरे ख्याल है ना।
जी जी जी
मेरे ख्याल से शुरू कर देना चाहिए। हाँ
बिल्कुल जी।
जी हाँ, शुरू करें।
लो जी, फिर साथ हम शुरू करते हैं फॉर्मली।
बिल्कुल सर, बिस्मिल्लाह।
बिस्मिल्लाह, बिस्मिल्लाहिर्रहमानिर्रहीम। यार एक कॉल आनी चाहिए और मैं रिक्वेस्ट करता हूँ साथ से कि वो तिलावत कलाम में पाक करें और उसके बाद हम प्रेजेंटर्स को देंगे। ओवर टू हिम।
थैंक यू सर। अऊज़ु बिल्लाहि मिनश शैतानिर रजीम। बिस्मिल्लाहिर रहमानिर रहीम। कुल हुवल्लाहु अहद अल्लाहुस समद लम यलिद व लम यूलद व लम यकुल लहू कुफुवन अहद। सदक़ल्लाहुल अज़ीम। I think Dr. Bajwa has just disconnected.
हेलो
जी सर,
आवाज आ रही है मेरी?
जी आ रही है आपकी आवाज।
अच्छा, भाई साहब डिस्कनेक्ट हो गए?
हाँ, मैं समझ उनको कोई कॉल आया शायद, इस वजह से वो फोन कैरी किया मैंने।
अच्छा,
2 मिनट फोन कर लेते हैं।
हम फिर डॉक्टर सफियान से कहते हैं वो अपनी प्रेजेंटेशन शुरू करें क्या? नहीं,
जैसा आप कहें सर।
हाँ मेरे हाल दुरुस्त है, ठीक है।
तो सर फिर आप वेलकम कर लें लोगों को,
से
और
स्टार्ट।
फिर आपको तो सारी चीजें पता है, हम टाइप क्वेश्चंस आंसर्स देंगे। और पहले जो है वो हम डॉक्टर काजिम का इंट्रोडक्शन, देन फिर स्पीकर्स जो है हमारे उनका, देन आपका व्यू, और फिर हम क्वेश्चन आंसर्स देंगे। तो सर ये जरा एक्सप्लेन कर दीजिए सर।
भाई तो मेरे हाल भाई साहब
आ गए
आगे
जस्ट।
आगे आगे, ठीक।
हेलो
जी सर।
जी, आवाज आ रही?
जी आ रही।
जी प्लीज प्लीज, सॉरी
सर
डिस्कनेक्ट हो
मैंने
गया।
तिलावत कर ली है। नाउ
जी
यू
सर,
कैन
जी
ओवर टू यू।
जज़ाकल्लाह। ठीक जी, थैंक यू वेरी मच जी। नाउ वी स्टार्ट फॉर्मल presentation of the journal club today. I hand over to Dr. Najat. Please continue. Hello.
Dr. Kazim, we could not hear from
Assalamu
you.
alaikum, everyone.
जी Dr. Kazim, please
Good
continue.
morning.
जी
First of all,
जी
thank you very much, sir, for giving me this opportunity for presenting our paper that was being submitted and been published in JPOA Journal Club. For that, with your permission, I want to request my fellow sports fellow, POA sports fellow, Dr. Noman Ashraf, to present the paper.
welcome please.
Please go ahead.
Assalamu alaikum,
Welcome.
and very good morning to everyone participating in this journal club. Can you all hear me, please?
Yes sir.
Okay, and can you see the presentation?
Yes, we can see you. Please proceed.
All right. First of all, I am Dr. Noman Ashraf. I've done my FCPS in trauma and orthopedics in 2020, and then I joined Dr. Kazim and Dr. Sufyan for the fellowship program in sports surgery and arthroscopy, sponsored by the PUOA at the Liaquat National Hospital, Karachi, from the 1st of March. So we're going to start with the presentation. The for which the topic is the single stage arthroscopically assisted reconstruction of multiligamentous knee injury with autografts. This article is published in the Journal of Pakistan Orthopedic Association in the volume 34, second edition in June 2022. These are the details of the authors and their affiliations. This article is cited as the following. So coming to the introduction, the multiligamentous knee injury is a very rare entity, maybe less than 1 per 100,000 hospital admissions. And of course, it is a challenge to treat. Basically occurs due to the high energy trauma or sports injury or road traffic accidents. Basically, the definition of MKLI is having the disruption of 2 or more ligaments of the knee, namely ACL, PCL, LCL, PLC, medial collateral ligament, and postomedial corner. The stars on the ligaments show that the most common pattern that involves 2 ligaments is the anterior cruciate ligament and the medial collateral ligament. Although the operative treatment yields better outcome, but the optimum treatment of MLKI is still controversial. The other controversies are regarding the timing of the treatment. It can be early or delayed. It could be single stage or 2-stage surgery. And either we go for repair or reconstruction of the torn ligaments, and what kind of the graft that we use. So that led to the hypothesis of this study, which is the single stage arthroscopically assisted reconstruction of MLKI yields good functional outcome. So the objective of the study was formulated, which is to determine the functional outcome of single stage arthroscopically assisted reconstruction of MLKI with autografts. So the basic components of a good research questions are following. The population under study is the adult patients with multiligamentous knee injury. The intervention done is the arthroscopically assisted single stage MLKI reconstruction utilizing hamstring, quadriceps tendon, autografts. In this case, there is no control group, and the outcome is assessed by the IKDC and Tegner Lysham score for the post-operative functional outcome. The study design is it is a retrospective descriptive study done from 21st of January 2017 to 21st January 2022. The study setting is the orthopedic department, Liaquat National Hospital and Medical College, Karachi. The inclusion criteria is the all adult patients with MLKI involving complete tears of 2 or more of the ACL, PCL, MCL, and postomedial corner and LCL and postolateral corner. The patients who presented after and operated after 3 weeks of sustaining injury were included. The exclusion criteria was the ligament avulsion, the open injuries, meniscal injuries, neurovascular injuries, knee fractures, and resurgeries. The surgical procedure done was by the same surgical team using the same technique for the reconstruction in all the cases. GE or spinal anesthesia was given. The clinical examination before anesthesia and after anesthesia were done, and then the arthroscopy was done to confirm the diagnosis and validate the clinical and MRI findings. The autografts of the semitendinous and gracilis tendon were used. Single bundle ACL or PCL reconstruction was done in all the cases. Semitendinosus and gracilis tendon from both knees were utilized when the MCL and one of the 2 cruciate ligaments were reconstructed. Quadriceps tendon was also harvested for the MLKI. So these are the some pictures of the procedures done. And these first 2 images show the in the figure A there is MCL avulsion, MCL injury, and figure B shows the torn ACL in the sagittal view of the MRI, and then the orthoscopic view of the torn ACL. Then figure D shows the harvesting of the quadriceps tendon, and figure E shows the tendon harvesting, and then the tunnel formation for the ACL and PCL. These are the orthoscopic images of the quadricep tendon graft for ACL reconstruction and the hamstring graft for the PCL reconstruction. These are the post-operative images which show the reconstructed PCL, this button, and the MCL, and then the for the these screw for the ACL. The rehab was standard rehab was advised to all the patients. Gradual mobilization was done from 0 degree to 30 degrees knee flexion on fifth post-operative day. Then gradually it went up to 90 degrees as per patient's tolerance. Touch walking was allowed. One straight leg raising was achieved usually at 6 weeks. Full weight bearing was allowed at 8 weeks, and follow-up visits were scheduled at 2 weeks, 4 weeks, 6 weeks, and every third month for the 2 years. The outcome at 6 months, 1 year, and 2 years follow-up was assessed with IKDC, which is International Knee Documentation Committee scores. The IKDC is basically scored from 0 to 100 and covers all the subjective and the objective parameters such as pain, activity, and those kind of clinical parameters. And severe symptoms or lower functional status has lower or close to 0 score, while no symptoms or better functional outcome has higher score or 100 score. Then the technical score is interpreted as excellent. That is score if the score is greater than 90, and good 84 to 90, fair 65 to 83, and poor the score is less than 60. The statistical analysis was done using SPSS version 27. Paired sample t-test was used to compare the pre-surgery and post-surgery IKDC and technical scores. The p-value of less than 0.05 was considered significant. The results. Total 35 patients with MLKI were operated with single-stage arthroscopically assisted reconstruction using autograft. So the mean age was 31.62 years plus minus 6.89 years. All the patients were male. Right MLKI was in 22 patients and left in 13. The etiology was most commonly RTA in 18 patients, sports injury in 11 patients, fall from height in 6 patients. So these are the results shown in the table form. The IKD score went up from the pre-operative value of 39.34 to 87 at the 2 years follow-up, and technical license score from 42 to 87 with the p-value of less than 0.05. This is the technical license score described as excellent, good, fair, and poor. At the 2 years follow-up, 6 patients showed excellent, 26 patients showed good, 3 patients showed fair, and none of the patients showed poor performance. And the p-value was 0.05. Complication reported are skin SSI in 3 patients and knee stiffness in 2 patients, which were eventually resolved with antibiotics and MUA respectively. So discussion and interpretation, the literature supports this technique as shown by the Ibrahim et al., who treated 20 patients with ACL, PCL, and posterolateral columnar tears with gracilis and semitendinosus autografts. And their follow-up at 44 months revealed license score of 90, and excellent results were noted in 6, good in 10, fair in 3, and poor in 1 patient. So they concluded 80% of their patient had functional stability and good subjective outcome. And then Finelli and colleagues treated 19 acute and 16 chronic MLKIs using bone, patella tendon, bone, and semitendinous and gracilis autografts. They also concluded, although these knees were not normal, but they were functioning stable. That is the prime goal. Literature also supports a single-stage reconstruction of MLKI as shown by the following studies done by the Jiang and Chen. The limitations of the studies are the design of the study was not specified as it is a descriptive study. So there was no control group, sample size was small, it utilized only autografts for reconstruction. They were unable to document functional outcome per ligament tears, and it is of course single center study. In clinical context, the excellent and good functional outcome was achieved with single stage arthroscopically assisted reconstruction of MLKI using autograft. This technique effectively restored knee stability and improved joint mobility. Complete pre-operative planning, of course, ideal patient selection and good surgical expertise are mandatory for optimum management of MLKI. There were no conflicts of interest and there were grants and fundings. So this study is basically a good structured, comprehensive, which clearly states the objective, but there was some problems with the study, such as study design was not properly identified, population intervention and outcome were of course clearly achieved, but there was no control group. And there was one other drawback of the study where the limited review of the existing literature in the introduction. So all the other criteria were met, including the ethical board approval and informed consent as well. Softwares used were statistical SPSS, and test employed were appropriate, and p-value was achieved, which was less than 0.05. And results were clearly stated, and statistically significant results were shown. So this article is published in the JPOA, which is indexed in the following journals and scientific indexing associations. So if you allow that we do share our some of our cases, then I can proceed with the cases as well.
Yes, you can. Please continue.
So this is how we do it. The first case is the 40-year-old male, which is a resident of Karachi, having no known comorbids. He was unable to bear weight for the 2 months. And on examination, he had all the following tests positives, including varus and valgus test. The investigation showed that he had all the multiligament injury, as shown by the MRIs of the left knee, and then it was classified as having KD4. So planned for single stage arthroscopy reconstruction was done of PCL, ACL, and open reconstruction of PLC and MCL. These are the tendons harvested and graft preparation. This is the quadricep tendon. These are the tunnel formations. So PCL reconstruction, then the ACL reconstruction, modified Larson method was used, graft was the hamstring, and anchor sutures were used. For the PLC and for the MCL, hamstring was used and the anchor suture was used. So these are the images, X-ray images, which show the MCL reconstruction using the anchors, and then the PCL using endo button, and this is the anchor for the ACL. Rehab, and then the weight bearing started as per guidance protocol. So these are the examination findings at the 12 weeks it is a valgus test done at the 12 weeks, and then varus test at 12 weeks, and this one is the anterior draw test done at 12 weeks, and then the posterior draw test. So this is the same guy at 12 weeks follow-up. The same guy with the doing squats. Then in case 2, it was a 20 years old student who presented with gross multiplane instability of left knee. Examination showed the following test positives, and these are the X-rays, MRI findings. So these are the arthroscopic images. There was meniscal root tear which was repaired arthroscopically, and their PCL reconstruction was done. These are the tunnel formation for the ACL and PCL. And PLC reconstruction was done using open technique. These are the post-operative X-rays. So these images show the this one is the button for the PCL, and this one is the tunnel for the ACL with the button, and this anchor is for PLC. So same, the anchor and the button for the PLC. The third case is 34 years old male with the following
please
test.
make it the last case one, please, because
Yes, sir.
people are make this last case, please.
जी sir.
Okay, please. Good.
अच्छा वो कह रहे हैं last. All right.
जी
Sir, last.
जी please. No, the third one should be the last case, I think. Yeah.
आपका आवाज सही नहीं आ रहा है, क्या फरमा रहे हैं?
मैंने कहा ये तीसरा केस should be the last one, ताकि लोग फिर they are willing to make some questions.
Okay.
Need, please.
So with that third case, I would conclude my presentation. If any of the participants have any questions. Last slide. So any of the participants have any questions from the authors? Dr. Kazim is here with me.
Saad, can you hear me?
Yes, sir, I can hear you.
Yeah, you please. Any of the audience, if they have any questions?
So before the question,
expert is also there, and the author is also there. You can frankly ask your questions. Preferably, you write down the questions, then we should answer you.
so I request.
सारे नमाज पढ़ रहे हैं? हाँ? टीम नमाज पढ़ रही है?
टीम नमाज पढ़ रही है, नमाज पढ़ रही है.
Good.
Washed up ना, इसलिए हाथ रेज किए ऊपर.
That's perfect. The studies was carried out between that was at 2017 to 2022.
Yeah.
And but Dr. Ben, did you join the department?
20. अभी recent.
Yes, I'm just a presenter. Basically, मैंने तो join किया है, मुझे 3 months हुए अभी.
The Kazim sir.
So,
Kazim sir is basically has done the procedures.
so
we started this subspecialty of sports medicine at LN Liaquat Nation since 2016, and this is very important, you can say, picture for us in which we, this shows a whole of the team, the armamentarium we have while doing a multi-ligament. And this we always work in a team, me and Dr. Sufyan both together, our ORP who we have trained. And in this, we reconstructed the 4 of the ligament of the patient in one single stage. So one aspect is, of course, the training, what we learn. Secondly, that's how we develop your skills. And the most important, which I will always highlight, which I always emphasize, is always a team which will going to make you to have the successful surgery at the end of the day. We always say me and Sufyan is not a 2. We always say me and Sufyan is 11, because one is operating, one is thinking, one is thinking, one is operating. And our ORP knows what goes back, who have to be on the graft side, who have to be on the surgical side. And that's which decrease the surgical time, and at the same time, it shows a good outcome.
Good. I think it's a very nice presentation, and it's a beautiful article and the investigation. This is one of the rare injuries, the multiple ligamentous injuries, and going for the reconstruction in one go. And a tremendous job done with beautiful results. Uh, it's really commendable, and really appreciate your effort and the work, and the quality of the paper was also very good. I hand over to Dr. Bakr Saab, and we are lucky to have him with us. He's one of the most senior person ortho surgeons in Pakistan and POA member, and past president and general secretary. Please, Bakr Saab, give your comments regarding this article.
Thank you very much, Professor Bajwa, Dr. Kazim, and Dr. Sufyan on the back of that. ये बड़ा अच्छा काम है. इस मेरा ख्याल है कि ये एक ऐसी जर्नी है जिसके थ्रू, जब बाबा साहब कह रहे थे इट्स अ रेयर इंजरी, रेयर मीन, अगर हम सारा साल ACL, PCL, medial collateral, lateral collateral और post-medial, post-lateral corner इंजरीज देखते रहते हैं, but there are sometimes individual injuries, and rarely there are multiple injuries. But the expertise and individual reconstruction makes you to go for the multiple injuries, or time factor आपका उसमें कम हो जाता है. इसीलिए that is required. From my point of view, जब multiligamentous injuries आती हैं, they are again on individual injuries, जिसको आप पिछले सारा साल कर रहे होते हैं, आप सारा साल ACL कर रहे होते हैं, PCL कर रहे होते हैं, MCL कर रहे होते हैं. So it's a joint venture. This is good. मैं एक comment था मेरा इसमें. The way back, जब हम लोग यह करते थे, तो whenever there is a anterior cruciate injury with the medial collateral ligament, and maybe questionable with the medial meniscus or the posterior medial corner, जिसको हम किसी वक्त कहा करते थे untried, the O'Donoghue, उसमें the standard teaching was you go for the ACL reconstruction. If your knee do not open in extension, it means you do not need any medial collateral or the posterior knee reconstruction. और हमने कुछ लोगों को किया भी था, or their medial collateral ligament was not repaired, and that healed eventually, because the central pivot point, which is the ACL and the PCL, if you reconstruct them, then the medial or the lateral ligamentous injury अगर है भी, तो उसकी instability जो होती है, that heal eventually. But currently, I think people are going toward immediate reconstruction of all the 3, 4, whatsoever is available. I think this is a good approach with the reasonably good results as compared to leaving them alone and heal by nature. How much time we expect that they will end up with the degenerative arthritis in due course of time? I think the long-term results are still awaited. With conservative, with 1 or 2 crucial reconstructions, or all reconstruction at a single time. So well done, Dr. Najah and your team. It's a good presentation and good writing. One thing I noted while I was going through the paper, outcome में आपने लिखा हुआ है severe, वो severe लिखा हुआ है, severe नहीं लिखा हुआ. Severe और उसमें फर्क है. उसमें जरा उसको स्पेलिंग को करेक्ट कर दें, एक दो जगह और भी कुछ उसमें था, वो इसमें दुरुस्त कर. Thank you very much.
Okay, so we have two questions over here asked by the attendees. If you allow, I shall answer them.
Yes.
Sure, please.
Okay, Dr. Sarmed have asked a question with KD4. What is the sequence of reconstruction protocol you follow? ACL, PCL, MCL, LCL, which one first and then second and third and fourth? Okay, for these multi-ligament reconstruction, we always do a single stage, and the sequence that is being published and which is being followed, we always go with a PCL, PLC, MCL, and ACL. So these are the sequence that we do. And in our one stage, when we always operate, we first of all do a very swift arthroscopy, diagnostic arthroscopy to see about the meniscus and to be sure about the ligamental tear. So then we will remove the both of, like if you're doing a multi-ligament, as we say KD4, that means ACL, PCL, MCL, and LCL all are gone. We take the both of the tendon graft from the hamstring. We take a quadricep tendon also. So what we do, we make a tunnels of the PCL and ACL arthroscopically first, because we know we have got 2 hours of tourniquet, and we have to finish this arthroscopic procedure. And when we have make the tunnels, we have passed our graft through it. We'll don't put a screw. Then we will go for the PLC first. Then once we have PSC is also been passed, now we will go into a sequential tighten and put a screw with PCL, then PLC, then MCL and ACL. I think so that what his question was. I think I have just answered it. The next question is Khalil Ahmed Saab, which is asking in MLI, multiple leg injury, like ACL and PCL, both reconstructed at same time, or first ACL, then PCL in one stage surgery. Okay, we always do a single stage. PCL and MCL goes together. If PCL and ACL is being teared, we always make a tunnel of PCL first. For its most technical aspect is putting a tibial tunnel for the PCL. So that's where more skills is being needed, and you have to have a posteromedial portal for it. You make a posteromedial. You have a PCL tibial jig. You have to put it over there, and then how we pass the graft. Then we make an ACL tunnel and pass a graft for ACL. We first tighten the PCL, then we tighten the ACL with the help of a bioabsorber screws. I think so I've answered the questions. Any other question? Most welcome. Sir.
So, as we have no questions, so over to you, Dr. Bajwa.
Yeah, it's a wonderful presentation. And I'm really thankful to the panel expert, Professor Abu Bakr, and the presenters, Dr. Noman Ashraf and Dr. Kazim. They are very nicely presented with very significant questions regarding the sequence and its detailed description, how they do it. I think it's the wonderful job is done. I really appreciate your effort, and thank you all of you for joining us for this club. And inshallah, we'll go announce the date of next Club of Pakistan soon. Thank you very much, all of you, and thanks, Dr. Sadov. You, Mr. Sayyid. Thank you.
Thank you so much.
Thank you very much.